Good afternoon, everyone. This is Morgan Scargiulo from the New England QIN-QIO, and thank you for joining us for today's webinar, Session 6 of Interact, Communication Tools Part 2, where we're going to talk a little bit about the red envelope as well. We've got Sheila, Eckenrode, Florence Johnson, and Dietz here to get us going. Before we do, I wanted to review a few housekeeping items. This call will be recorded for training purposes, and I'll provide you with details on accessing that at the end of the webinar. I'm going to go ahead and mute the phone lines one more time. We will take questions at the end, but we'll instruct you on how to ask a question at that time. If you would like to pose a question during the presentation, you can do so in the chat box at the bottom right of your screen. And please make sure to send your question to all participants so that we can keep up with the incoming questions. I will now pass things over to Carol to get us going.
Good afternoon, everyone. Welcome to our 6th session on Interact 2016. We are all excited to be here and to help continue on this wonderful journey of implementing Interact throughout your facility. And as Morgan mentioned today, we're talking about communication tools externally. What tools you're going to be using that are going to be sent out with your patient or your resident as there is an acute care transfer. So today's objectives for the day, we're going to talk about SBAR as we have talked about it before, but we're going to just reemphasize the use of SBAR not only internally, but how you send it out, send that form, the completed form out when you do an acute care transfer. We're also going to be talking about the nursing home transfer form and the acute care transfer checklist. And also, we're going to be talking about the nursing home capabilities checklist, and also the use of the red envelope as you are preparing your patient for the acute care transfer. And then Sheila is going to be talking about process mapping, and this is a very important quality improvement tool that should be used as you are implementing a new tool or a new process in your facility. And so I hope you'll be listening closely with your team as Sheila discusses process mapping. As we always do when we start a session, I just want to make sure everybody is still understanding what it is to get an Interact participation certificate. Again, I just want to go through the requirements. There are 9 webinars. You have to participate in 7 out of the 9 webinars, and you have to send us at least 4 months worth of readmission data. So the internal Qualityne team has access to Advancing Excellence, so we are monitoring that on a monthly basis. If you are using that tool, we can see your data. If you have given us the data use agreement that you are allowing us to see your data, or you can also send us your data via email or fax. We do not want patient-level data. We only want your readmission data by month. We want the aggregate data. And if you have any questions at all, please call Florence, myself, or Sheila, and our contact information is at the very end of this webinar. We're not done yet with the requirements. This is a new requirement, 2016, and when your nursing home administrator signed the participation agreement, this was on it, that at the very end of the webinar series, we are going to send out the Interact checklist for all the tools that you have implemented, and they're basically verifying that, yes, these tools have been implemented and they are part of our everyday work. So if you have missed 1 or 2 sessions, you can go back into our website to view a webinar, and this is our website address at www.healthcarefornewengland.org. And this is how you get into the area where you can view the previous webinars. And again, if you have any questions or concerns, and we do monitor this on a monthly basis, so we see who goes in and watches the webinars. But remember, Of the 9 webinars, only 2 can be watched online. The other 5 of the 7 out of the 9 you must be participating on these webinars. It's so important to listen to when we have our sharing session at the end. It's important to hear lessons learned and challenges other people are having so you can also help your team go in the right direction. So these are the Interact sessions thus far. March, April, May, June, and July. This is a nice slide for you to have if you have missed a session. And so with that, I'm going to turn the session over to Florence, who's going to be talking about the Interact communication tools that you're going to be using externally.
Here you go, Florence.
Thanks, Carol. As Carol said, it's very important that only 2 of your sessions are viewed online because for a very important reason, you need to have that time to implement the tools that are taught live. So if at this point you've missed more than 2, unfortunately you will not be eligible to receive a participation agreement for this session. So let's move forward, and I love polling questions, so here's the first of 3. Could you please answer this question? My facility has started inputting data into, and then just click on whichever one you're using. Don't forget to push submit so that your answer will be reflected.
And we're going to sing to you while we're
That's Carol going to sing, not me.
Marty, again? Yes, I need to discontinue the
All right.
So we have 12 seconds.
2 more seconds.
I need it picked up. She's got osteomyelitis, so yeah.
And please reach out to me if you're having any difficulties at all using the Advancing Excellence website to submit your data. To me, it seems easy, but I know if you're just using it for the first time, it might be a bit more difficult. All right, great. So we had 28 people not answer. Now that's kind of concerning. If you're doing this work, you really should be collecting data and tracking your data in some format because that's what helps you drive the work.
Yes, it'll be in the medication room on 2 South.
All right, so the next polling question.
Oh, that's okay. She has nursing.
All right, hold on 1 minute. We're having technical difficulties. Technology works and it's great. When it doesn't, it doesn't.
MRSA. Yep.
No.
Yeah, that's fine. Yep, not a problem.
Hands up. So have you implemented the SBAR tool in your facility, yes or no? So if you could answer that question, that'd be great.
All right. Sorry, we're having technical difficulties. 1 second. All right.
So, yeah, go ahead and answer the question. Have you implemented the SBAR tool in your facility? We talked about this last month.
Not allowing us to?
All right, thank you. I'm working on it.
Sorry, we're testing out a new feature with the polling, and apparently it's not cooperating. So bear with us 1 second.
All right, let's just move on then. The next polling question is, have you implemented stop and watch in your facility? All right, it looks like it's working now. All right, we still have a few more seconds. And hopefully you do have a process in place on how to really get that stop and watch going in your facility. I think it's the base of all the communication that happens in your building. Your ancillary staff is very instrumental in catching any nuances that are changing in your resident. And you want to have a system for them to be able to communicate that and communicate that effectively to the nurses and your providers. All right, great. 35 out of 66 have started using stop and watch. That is so awesome. I am very impressed. We're not going to sing for you though.
That's excellent.
Okay, so now we'll move on to what we want to talk about today. Today we're talking about external communication, so communicating with your acute care providers. And essentially what this is how are you providing your transfer information when you have to send a resident to a hospital, to the emergency room. So on the screen are tools that you should be using. Your SBAR tool, which we talked about last month, is the clinician, the LPN or the RN documentation on what this changing condition is. What are you seeing? What's making you have to transfer the resident? And then we have the nursing home transfer document. This is also available on the Interact website. It includes everything from the goal status, goal of care, function. It basically replaces the W-10 and has a lot more information, more detailed information than the W-10. So as a state, our Department of Public Health has given us permission to no longer use that form that's called the W-10 as long as all the essential documentation information that you need is on the form that you're using. So as a state, we have agreed that instead of the W-10, we will now use the nursing home transfer form. And feel free to reach out to any of us if you need to get more detail or if you need that DPH documentation, the fact block that went out a year ago. And then also we're asking you to include your capabilities list because this lets the emergency room in the hospital know what you're capable of. So if you're capable of doing IV LASIK or if you have a respiratory program in your building, you don't want them keeping your resident when you're able to provide that care in your own setting where the resident is more comfortable. And then we will also have you use the Acute Care Transfer Checklist, which is placed on the outside of the red envelope that shows exactly what is included in the envelope. It's just a reminder to you also to make sure that you've included all elements of that red envelope. So as I said, the SBAR, which we all know stands for Situation, Background, Appearance, and then a request from the physician. So you're basically in detail writing what it is that's bringing the resident to the hospital. And the transfer form, as I said, is a form that tells exactly what's going on, what their usual mental status is, their functional status, key clinical information, isolation. We are asking you to print down the face sheet of the resident information because it has more demographics in there, and it also has their the primary caregiver's contact information. So I think when people in our state talk about interact, they basically list 3 items. SBAR, the hospital tracking tool, and the red envelope. And I'm very happy to know that across our state, the red envelope initiative is really sticking. It's becoming the way to send information to hospitals. And our goal in this interact work that we're doing is that if nothing else sticks, the SBAR sticks, and then the red envelope. We want to make that a standard across our state. So we started this work a few years ago working with communities of care within our state, and I'm sure you all are all familiar with that. It didn't really grow as well as we wanted it to grow, so we took a step back. We did what we always tell you guys to do. We did our TDSA cycle. We looked at root cause analysis. Why is this not working? So we found that we did not educate all the people that had a hand in patient and resident transfer. So we took a step back. We brought all those people into the room, such as CMS, the corporate entities, ER docs, and case managers, and we really talked about this red envelope process and how we want it to look. So thanks to them, we now have a process that we think really works well. So you want to make sure that when you're doing your transfers, everything that's in the envelope has to be copied and given to EMS. The only thing that really EMS doesn't want is your capabilities list, because that belongs to the hospital. The hospital needs to know what you're capable of so that they don't keep your residents unnecessarily. A lot of these forms you can pre-fill parts of it ahead of time. People, you have to figure out what process works for your facility. So, again, we've gone over what's in the envelope. It does not have to be signed. There's a document on the checklist says that the emergency medical services provider needs to sign it. That has become a stumbling block for us and has become a barrier. They don't have to sign it. As long as you give them their copy, the red envelope should be intact. Again, let me just go over it. You want to have your MAR, a copy of your MAR, to show what meds the resident is taking when they took it last. Now, I've had people push back and say, we don't want to send copies of our MAR because we don't want the hospital seeing the holes that in case meds were missed. Trust me, the emergency room barely has enough time to really read what you're sending them. They are not going to take a microscope to your MAR and say, we're reporting you because a medication is missing. Unless you can come up with a different way of communicating the medication list and when the med was taken last, this was the best way that we found to work. You need the face sheet from the resident, as I mentioned, any DNR orders, any other advanced directives. If you have someone that's conserved, you need to add the conservator's information. So think about it like this. You're sending a resident who cannot speak for themselves to the emergency room. So you want to provide the emergency room staff with enough information that they can pick up this resident and be able to tell what's going on and what kind of treatment they need to provide. But then at the end of this, it's also nice, we talk about that warm handoff, so call the emergency room ahead of time and just talk to the triage and say, I'm sending you Mr. Jones, the red envelope is coming with them, but I just want to give you a quick, brief synopsis of what's going on. It's all about communication and making sure that we are all on the same page. It's important that you seal the red envelope when you're giving it to the emergency room, the EMS staff. There should be no need for them to open it if you've made a copy of everything in there for them to have. The goal of this is to keep all the forms together and to standardize the process and to let the emergency room staff know exactly what they're looking for. So if we get this standardized across the state. There should be no more, sending residents to the ER and the emergency room department not knowing who to call because your contact information will be there. There should be no more question about why is this person here. All right, and that's it for me. I will now give it over to Sheila.
Thank you, Florence. Good afternoon, interactive partners. I'd like to talk to you a little bit today about process mapping. This is a QI tool that some of you might have used, and if you have, please tell us a little bit about how that worked for you in our sharing session. But for the folks that haven't, let me describe it to you. Process mapping really is a way of understanding your current way of doing something with an eye towards designing a better way. So it's defined as a method for displaying processes and illustrating how transaction happens. It's a visual representation, and that's an important piece of this because once you kind of can look up and see it step by step, you'll learn a lot of things. It should be done in enough detail that someone who's unfamiliar with the process would be able to understand what's going on after looking at the map that you've made. Unintended benefit of process mapping is you'll often find things happening within a group or within a process that don't need to be there. And I'll give you an example from my work here at Qualidigm. When I first came here, we had a project that I managed, and part of the process that I was told was that everything that went to CMS had to go through the U.S. mail, which of course added about 5 days to every deadline. So we sat down and we were mapping out that process with an eye of changing it, making it better, and somebody said, who says it has to go through the U.S. mail? And around the table, not one person could remember where we got that. So we called CMS and they said, we don't care if you FedEx it. So here's stories like that, process mapping a lot, where somebody will say, this is a piece of what we do, this is how we do it, and other people will say, that's not how I do it. And you'll find some variation in how things are done. So I would definitely recommend trying this. It's a good thing to do. And I'll give you an example. Let's say I'm feeding my cat, and if you have a cat like mine, it walks, sits, and sleeps everywhere but the floor. Their little paws barely ever touch the floor. It's always on a counter, always on a refrigerator, always in a bed. So I'm going to feed the cat this morning. So let's look at a high view of what I have to go through to get that done. Get the cat dish, put it on the counter, open the door. First decision, and in the web process mapping, decisions are indicated by these little diamond shapes. That's important because that's where a process is going to bifurcate and you have two different ways to go. So I'm going to feed the cat, let food or dry. If it's dry food, open the bag, pour it in the bowl, cat jumps on the counter, take the cat off the counter, put the bowl on the floor. I'm done. But maybe the cat needs wet food, having some problems with his little kitty cat teeth. So now I have to find a can opener. I got to get the can opener, cat jumps on the counter, put the cat on the ground. Open the can, cat jumps on the counter, put the cat on the ground. Scoop the food in the bowl, cat jumps on the counter, put the cat on the ground, put the bowl on the ground. So you can already see that this process has some redundancies in here that could be taken out. For instance, if I locked the cat out of the kitchen while I fixed its cat food, I'd probably eliminate 3 steps to this. Those are the kind of things that you're looking for. So at a very high level, you want to assemble a group that's familiar with the process, people who actually do this. And again, it's important that it's a visual representation. It just makes a big difference in how we call it degrading a process, but what we're really talking about is getting the detail, fleshing the detail of a process out. By putting it up on a wall, either on a chalkboard, sticky notes work very well. And ask people to step by step document exactly how they do something. And you're looking for redundancies, you're looking for inconsistencies. One person might have a different way of doing the same amount of work. So you want to lay it all out there and then kind of look at it and think about what could be eliminated, what could be done better. So you get that done. So it might look something like this. And this is a very high-level process, or a high-level look, I should say, a high-level look at transferring a resident out of a skilled nursing facility. And again, there's many more steps in here, and you might want to, as a group, really break it down and go step by step what happens. But you see, you're going to assess the resident, you're going to get some vital signs, you're going to assess his pain, look at his symptoms, call the supervisor, call the APRN. We're assuming the APRN has advised you to call an ambulance. In the midst of all this, probably several times in this type of process, you're going to be reassuring your resident and family. At the end of it all, you might document the assessment after you've done all these other things, report out to EMS when they come, and then you start copying the MAR and assembling the documentation. So say you want to weave Interact into the new process, you're going to ask your staff to outline step by step what using the red envelope might entail. Document the results. Again, you're looking for redundancies, you're looking for inconsistencies. Run the new process after you've mapped it out, after you've decided how it's going to be done, and then regroup after about a month to talk about how it's going. So the new process for using a red envelope might look a little bit more like this. You've assessed the resident, gotten some vital signs, you started your SBAR. Somehow on this it has to be an SBAD, but we all know what it is. You're calling the supervisor, calling the APRN, documenting the APRN recommendations on SBAR. So you're weaving the documentation into what you're doing, so it becomes a little less burdensome at the end. This is actually a process flow map that one of the nursing homes that I was working with put together. So this is how it was working to them. You're calling the ambulance, reassuring the resident, reporting out to EMS, copying the MAR, completing the transfer form, copying all the documents, getting the red envelope together, and handing it over to the EMS. So if this is something brand new to you, I would definitely recommend that you try process mapping. I'd be happy to come out to a facility if you'd like to help you with this. I'll tell you, it's fun. It's usually energizing. It gets people involved, and a lot can be learned from it, and it also gives you the opportunity for a clean slate to design a process in the most efficient way. So thank you for your time, and I'm going to turn this over to Carol.
Thank you so much, Sheila. That was excellent. So our next is our sharing session. So we have Florence and Sheila in the room. So can we open up the phone lines, or if anyone has a question before we go into our sharing session for either Florence on the communication documents, the external communication documents, or the red envelope, as we like to lovingly call it, or on process mapping for Sheila before we go into our homework from last month and our homework for this month.
So if you have a question, if you'll press #6 on your phone to unmute your line, and then I know some people also manually muted their own line, so make sure you unmute your phone and press #6.
Can you hear me?
You can.
Can you repeat, when we send our red envelope to the hospital, I don't believe we're also giving copies of the forms to the EMT. Can you repeat which copies the EMT needs?
They need everything you're putting in your envelope except for your capabilities list. So they need the SBAR, they need your MAR, they need the change in condition document that we talked about, which is replacing the W-10. So everything that's in that envelope they will need, because they need to document the transfer also.
Okay. So do I also need to keep a copy for the chart?
No. You need your SBAR in your chart because that's your documentation.
Right, and the transfer form too.
Okay, so the whole red envelope goes to the hospital. The whole red envelope minus capabilities goes to the EMT, and the facility just keeps SBAR and...
That has saved me.
What does the facility keep?
You keep your SBAR, which is your original document, and you also keep a copy of the transfer document, kind of like when you would have a copy of the W-10.
Okay.
Yeah.
But don't forget to also, in that red envelope is the, face sheet and any advance directives that the hospital may need to continue on with the care.
Okay.
Because the face sheet has the insurance information, and that's part of the public health code, that says that information has to be transferred with the patient.
Okay, I just wanted to know what the EMTs, I think if we fail to give them copies, they take stuff out of the envelope.
Correct.
So
while you're
I
at the
understand
machine,
now.
yeah, you just make 2 copies of everything. So one goes in the red envelope and one goes to EMT.
Perfect. Thank you very much.
You're welcome. Any other questions?
This is Sheila. I would want to share, when we first started doing this work, we were surprised at how much information the EMTs wanted. And when we went out to look at their charts and the data they collect, it's amazing how much information they collect and feed up to the Department of Public Health. So a lot of the stuff they collect on our patients about medications, reasons for transfers, and run times becomes part of what, our public health budget grows out of, public health strategy. So I felt more committed to helping them collect that information, in addition to needing it, of course, just for the run and to know the patient and to be able to treat the patient en route. They're not just throwing out those papers at the end of the day, I want to say, and not discarding your hard work of copying them.
And we truly partner with you in this work. So if any facility is encountering an EMS group that knows nothing about the red envelope or feels uncomfortable with it, please contact us so that we can provide education to the EMS group. Because what I've learned is that we contacted the private EMS companies and educated them, but we totally forgot about the town EMS, who are sometimes the first responders, and they get onto the scene and they don't know what you guys are talking about when it comes to the red envelope. So we are here to educate not only you but your partners so that we can make this a seamless experience. So let us know if you come across any of that.
Okay, there's a question in chat. The question is anyone using the SBAR with consult?
That's
a great question.
Yeah, I actually was working with a facility not related to this. About 2 years ago, I was doing, and this is Florence talking, I was doing chart abstraction for another research study that we were doing. And yes, I did see people using the SBARs for consult. That's a very excellent tool to use because it gives a lot of detailed information about why this person is coming. And I know people say the SBAR is cumbersome because it's such a large document. Just remember, you're only completing the parts that relate to the change in condition of why you're writing that document. Any other questions?
It's #6.
It is #6 to unmute your line.
I'm sitting on my hands, giving a few minutes for people to think.
I think we did such a great job. They don't have a question.
I get it.
All right, as you think of your questions, remember #6 to open up your phone line. So now, anyone? Okay, so let's talk about our homework from our last session. So we talked about the the Interact QI tool last month. This is a very, all the tools are important, but this is really like the foundation of the work of Interact. This is basically documenting why an acute care transfer happened. And also you're looking at all the processes of that patient being transferred out, whether it's just to the ER or if the patient is admitted. So anytime there's an acute care transfer, this QI tool should be used to document why that patient went out. And was there something that was missed or something the facility could have done to prevent that transfer? So the homework was your team was going to review the tool together. The team was going to discuss how you're going to pick one unit to implement the tool, which unit, how you're going to educate your staff. You were also going to talk to your leadership as well as your medical staff because they need to know that this tool was being used and how they are part of the process. And then you were going to use the tool for the first time for your first acute care transfer on that one unit you had chosen, and then you were going to debrief. So that's what this discussion for this afternoon is all about. So does anyone have any lessons learned about using the QI tool or about educating your staff? Have any success with the tool for the month? Or if you've been using this tool, do you have any lessons learned that you can share or any barriers that you may have encountered? So if someone could start us off, #6 to open your line, that would be great. Tell us how it went this month. You have a minute? Come on. Hey, Billy Boy. Do you want to tell us how it went last month? #6.
Hi, Florence.
Hi, Billy.
Thanks for calling me out.
You know I'm good at that.
Wonderful. I'm sorry that I was in a conversation. Could you just repeat this?
That's my guy. Be honest. Did you use the QI, the root cause analysis tool that we talked about last month with any transfers that you've done since?
Yeah, I used it over at Chelsea. I used it on everyone that would go out. I did it for a review and just kind of kept it on the desk over there, and then reviewed it with the administrator if there was any chances for improvement. But yeah, I used it every time somebody went out. I would look at it.
Good, very good. So what did you learn?
Some of it is too in-depth, to really sit there and go through each individual thing, but as a guide, I'd use it, and you would find out, like, geez, could we have done A, B, or C differently? And then I would, again, go back to the administrator, talk with them, see if we could talk to the staff. It's a pretty good tool to put everything together.
Hey, great, thank you.
Can I go back to mute now?
I think Carol has something else for you.
Did you learn? Can you share at least one thing that you've learned or that you've changed in how you take care of your patients because of using this root cause analysis tool?
I think that I don't know if it really changed, but it made us emphasize more on the stop and watch. To be able to go and say, okay, are we getting that small change? If someone starts their personality, or they become a little bit more not responsive as usual. That's what I started seeing with our nurses' notes, was that, there's a slight change right there that we have not, maybe not pick up on with behaviors and things like that. So I think that it made us focus a little bit more in on that initial small change.
Excellent. Excellent. Thank you.
Thank you, Billy. You keep
all right, thanks, guys. Bye.
Bye. All right, would anyone else like to volunteer before I call you out? Going once.
Big one for the team.
Going twice. All right, let me see. Donna Stengel. I know you're on. Unmute yourself, pound 6. Come on. All right, while we're waiting for her to unmute, how about Giovanna? Can you unmute your line and tell us how you've used the QI tool?
Yeah? Oh, hear me. Oh, great. We actually reviewed, we're a little basic here, and we reviewed the Stop and Watch and the Interact forms at Medical Board in July. And, you know, the Stop and Watch is new to the doctors looking at it, and they had some questions and concerns. And we answered their questions, and we're starting in September. We're actually in state survey right now, so we'll begin this probably the second week in September.
Hi, Giovanna, it's Sheila. That's a great way to start, getting support from your medical staff. It's a really good place to be. And they're out there in the world, and they're speaking SBAR when they talk to clinicians from hospitals and home care. So kudos to you.
Okay, thank you.
To talk like that.
All right. Donna Stengel, one last chance. How about Lynn Thibodeau? Hey, buddy, can you unmute yourself, pound 6? Lynn, are you on? Hello?
That's a pre-holiday doldrums.
All right. Sheila Johnson, can you unmute yourself? We can hear you. Okay. If you don't unmute this month, I'll be getting you next month. All right. Let me go to John Kelly. Are you on? Hey.
Hi, how are you?
Good. How are you?
Good. We've been using the red envelope. I'm not sure if we made copies though for the EMTs. I'll have to double check that with my director. But you know, Stop and Watch, I think has been just I see the sheets up on the units when I'm making rounds. I know the staff are using it, and even the family members have used it.
That's great.
But yes, I am here. I am live. I am listening. Not like that.
Well, so is Lynn. She just typed. Oh, thank you, Don. Thank you so much. Lynn just typed in that they've been utilizing the QI tool for quite some time now at Riverside at this point. It is a valuable tool to review transports and see how we can improve upon our process and review any procedures to improve upon. Thanks, Lynn.
One of the things I'd like to say that if you're a facility and you'd want to get on a preferred provider list, being part of this webinar series is very important in getting that participation certificate saying that you participated with us. But using the QI tool regularly as part of your daily work will show the hospital that you are truly involved in improving the care that you provide. They highly recommend and they highly are looking at facilities that are using this QI tool. So please know that this is a very important tool to have in your toolbox.
And Brenda chatted in that she really likes the idea of using the SBAR for all consults. You might as well if you're using that as your patient condition documentation, so that's really good. And Lynn is apologizing because their phones went down in Riverside. Let's see, who else? Anybody else want to volunteer before I call you out? How about Mandy? Mandy, can you unmute yourself, pound 6? while we're waiting for Mandy to unmute, Brenda also chimed in that Interact tool use is giving them points with their ACO.
Yeah.
Most
And,
definitely.
and that's a consistent message you'll hear again and again.
Hello?
Hi, Mandy?
No, this is Terry Conway from Cheshire House.
Oh, hi, how are you?
Good, how are you? Listen, we've been using this Interact tool now for about 2 months, and the SBAR, and the hospitals love it.
Yeah.
They love it. I kind of wish the hospitals would use one too when they send them back. But the only thing is they get that transfer form out. Sometimes the SBAR might take a little bit longer, but within 10 minutes of that resident being sent out, especially if they're on the floor bleeding or whatever, that SBAR will go out and they restock the ER with it. And they appreciate that. So, my medical director is 100% on board with this. He actually likes the tool himself. So, and the staff has been very cooperative with this, and they do it all the time now. It's just second nature to them.
And that's exactly what
Thank you for mentioning that about the fact that if you have a real acute situation, you can send the resident out and just follow up with the sending out the information via fax after the transfer is already happening.
But I think it's a great tool, and I think it's a big help to both the facility and the hospital for continuity of care.
Absolutely. Thank you.
Thank you.
I just want to read in chat. Heather noted that they have their medical staff meeting tomorrow morning, and she will be discussing this with their medical director and start the process in servicing their staff. Thank you. That's exactly how we want this to work, is that you engage your medical staff and you engage your leadership, especially if you're just going to start now, but it's never too late to loop them into the work that you're doing, because we need their support to make this work.
Okay.
I think I'm done picking on people for this.
So let's talk about homework, and hopefully this will help you process out how you're going to educate your staff for this month, for these tools. So for the homework for this month, the team leader will download the copy of the SBAR form, the nursing home transfer form, the Acute Care Transfer Checklist, and the capabilities list from the Interact website. And then you're going to save each of these documents on a shared drive of one of your facility's computers, and let the team know, and other staff members who may need access to these, if you run out of copies, somebody will always know where to get more copies from. So that's why this is always part of the homework. The team leader is going to be talking with your vendor, your facilities vendor, about purchasing red envelopes. All right, so you need to make sure that you're there in-house before you start saying, we're going to start using them. So you have to make sure that you're going to purchase them. And then you're going to look, the team leader is also going to look to where your copier or copiers are located, along with all the other supplies that go with the copier, like your paper, your toner, your tape, as it relates to the acute care transfer process, because you want to make sure, as you're going to process out this new process, adding these new documents, that it's going to be an easy process for if the staff has an acute care transfer, everything's going to be right there to them as they're calling 911 and they're assessing the patient, and another team member is getting these forms together for them. So then the team leader is going to schedule 2 meetings with the team this month. The first meeting, with your team, you're going to look at all the different Interact tools that we talked about. You're going to discuss how and when your staff nurses, the supervisors, and the leadership will be educated on each of these tools. You're going to decide where the copier should be located and the needed supplies on each unit, and make recommendations to your leadership if there's a change that is needed. For example, you may need an extra copier, or you may need to move your copiers. But that's something that the team can discuss as you're mapping out the acute care transfer process. And then you also want to make sure that you have the red envelope in your facility from your vendor. So then the second team meeting is that's where you're going to actually map out your current acute care transfer process. And we recommend that you bring in at least 2 frontline staff if they're not already part of the team. You're going to bring them in to help with the mapping out because they do this, maybe not daily, but on a weekly basis. They're the ones that are actually doing the transfer. And then you're going to map out how you would like the acute care transfer process to look. Adding in these new documents, adding in the red envelope, adding in the copying of the forms, because again, one goes in the red envelope and one goes to EMS. And then you're going to discuss how and when the staff and nursing supervisors are being educated and is it working? Is it being done? You're also going to decide which unit is going to begin this new process. Again, you're going to start 1 unit, 1 nurse, and then you're going to do a debrief after they have that first acute care transfer to see how it worked, what didn't work, and then you're going to do you're going to make it a little better. That's what we call a PDSA cycle. Sheila has talked about that in the past, to make it better, and then you're going to spread it to a second unit. And again, educating the staff and seeing how the process goes. And after each time it goes, the team should sit down with the nurse that started the acute care transfer to say, hey, how did it go? What worked? What didn't work? So there's a lot of work, a lot of homework to be done this month. And again, we're literally a phone call away. Here's our contact information. And if you are running into a snafu, or if you'd like Sheila or myself or Florence to come out to help you with your process mapping, we can do that, because this is how important it is.
There's a question in chat to go over again the participation, the certificate requirement.
Sure. So I'm going to go all the way back so people will get busy. Don't look. I'll tell you when to look. Okay, here we go. So, there are 9 webinars total. We're at session 6, so we have 3 left. So, in order to get a participation certificate, you have to participate in at least 7 out of the 9 webinars. 5 of the 7, let's say you hit the minimum, but you only participated in 7. Only 2 of those 7 can be done online. So you haven't participated, you've actually gone into our website, you watched the webinar. That's the key. You have to watch the webinar.
It says download the recording, and that's what you have to watch in order to get the credit.
Right. So not just the slideshow, you also have to download the recording, so you actually have to listen to the webinar. So that's the first piece of the requirement. The second is you have to send us, Qualidine, Florence, myself, or Sheila, at least 4 months worth of readmission data. And the reason why we have chosen 4 months is because once you hit that 4 months of looking at your data, you're going to realize how valuable looking at your readmission data is. What day of the week are they going out on? Is it a certain physician that's sending them out to the ER? Is it a certain shift that's sending them out to the ER? So that's why we said 4 months. Now, if you're using the Advancing Excellence as your readmission tool data submission, and you have given us permission through the data use agreement for us to view your data, we can go online, Advancing Excellence, and look at your data. However, if you're not using Advancing Excellence, and let's say you're a corporate entity, you're part of a corporate, and they have their own readmission data tool that they're using, just send us 4 months worth of it by email, by fax. We don't want patient level. We want the aggregate. What is your monthly readmission rate? We're not done yet. So participation in our webinars, 4 months of readmission data, and your nursing home administrator will have to complete the Interact Tools checklist at the end of the webinar series to verify what Interact Tools have been implemented. So those are the requirements for a participation certification.
And for those of you who are more seasoned and have been doing this, we're taking it step by step for those people who need support in implementing each of the tools. If you're a facility that's been doing all these things and you're doing it to get involved in an ACO or preferred provider, that's fine. You still need to be on the calls. You need to share on the calls and submit your data so that we can verify that you're actually doing Interact. Because at the end of the day, I always say this, it's not about checking a box. It's about actually living what Interact tells us and what Interact is trying to get us to do, which is changing the way you do business. Doing it because it's the right thing to do. It's about quality improvement, because at the end of the day, the residents remain in your building and they deserve the best quality care from all of us.
So there's a question that just came in from chat. So we have a certificate from last year. Do we need another certificate for this year? No, you do not. However, we're pleased, we're honored that you're on the call with us. So when we are having our sharing sessions, you can tell your colleagues lessons learned, best practice, what worked for you, what didn't work for you. So you are valuable to us, the team, the internal team here, as well as to your colleagues throughout the state. So, and I just want to share with you, our readmission rate in the state of Connecticut has been going down. And we here at Qualidime really believe it's because of the work the nursing homes are doing. We really have seen a drop. We are so honored that you're sharing this time with us. But it's all about the patient and all about your resident, and that's why we're here.
And because I'm so competitive, this is one, I want to be the state that can be put on the map for actually having all of our nursing homes implement Interact and make sure that we are the ones that are doing it and doing it right. Missouri did a little bit a few years ago, but I want to beat them, so join me in my competitiveness.
Okay, we have 3 minutes left. Right. Does anyone have any questions? Sure. I'm going to the contact slide, so you got to make sure you can have our phone number. Sorry if this is getting people headaches. There you go. There you go. So pound 6 for the last minute or so, if anyone would like to have a question.
Have a good afternoon. Thank you to those who actually let me make you speak. Appreciate it. So we'll see you next month. Have a great afternoon.
Bye, everyone.
Thank you.